So today is more going to be a focus on what us nurses can do for our patients, being a real advocate for our patients, and also for the carers, because quite often our cardiac patients are coming in emergency situations and they're quite critical. And especially cats can have an underlying cardiac disease and it's not known until something really bad happens. And these poor carers are coming in and we then have to give them some really bad, news that their patient, their beloved pet has got an advanced cardiac disease. So we really need to step up as nurses, be the advocate there for our patients, but also to support our carers in these really difficult times as well. So hopefully the aims of this presentation is going to improve your confidence in recognising and responding to cardiac emergencies, because quite often these patients come in and they're in respiratory distress. Is it actually cardiac? Is it respiratory? Is it pain? So we need to, just to help us along to say, okay, let's treat this as a cardiac emergency. We need to understand the key nursing responsibilities in these situations. Obviously, we have to be guided by our clinicians, absolutely. But us as nurses can step up and give some, can we do this? Can we trial this? Actually, can you hold on a minute because our patient's really stressed? So it's just to go through those key aspects as well. And obviously, when we have our cardiac emergencies, we have to act quickly, very quickly, but safely, and make sure our communication is key. So we need to be able to have a good team around us, have a communication with our team, also have roles, because some of these patients are coming in and will need, emergency treatment, they may need CPR. So communication with the team around us is key to our patients. So, as I said, the learning objectives already is to recognise the common cardiac emergencies and how they present to our hospital, to making sure that we can act safely and effectively for our patients. How to support our patients with heart failure. It's not an end kind of goal for our patients when they come in with heart failure. People, when you hear about heart failure, quite often carers like, it's horrendous, it's awful news, but we can keep them nice and comfortable, and we can keep them, have a good quality of life, because that's what it's all about. It's not the amount of time, but it's the quality that these patients can have when they've been diagnosed with quite a significant cardiac disease. Arrhythmias, we've already talked about arrhythmias, it's my favourite subject of all. I get very excited about arrhythmias, you'll probably see that in a moment. Obviously know what is good for us to do as nurses, and obviously then supporting our clinicians in these difficult times as well. And I can't stress enough, obviously, about the support for the carers. We have to be there for them. Communication is the key for our cardiac patients. Okay, so some of the common cardiac emergencies that we see. Acute congestive heart failure, we see that, in cardio where I am now, we see that on a daily basis. They either come through ECC and we support our ECC team, or they come straight through to our cardiology department. Arrhythmias, pericardial effusions. Do you guys, are you quite happy in your practices? Do you do your own pericardial centesis? Yeah, great. Are you all happy about that and the challenges that can pose? Not nodding heads at the moment. Okay, we can go for that, that's fine. And I think I've been a cardio nurse for quite some time now, and I think aortic thromboembolism in our feline patients is one of the saddest cases that we see in clinical practice. We had one literally this week, and it was a 4-year-old cat that came in affected. And quite surprisingly, there was 3 limbs affected. So the poor prognosis for this patient, it was really, really sad actually, and the carers thought that their little one had been involved in an RTA. So we had to actually give them the news that actually no, this is, it's a horrible diagnosis. So we'll go through that, but I don't know. Yeah, we'll talk about that a little bit later on. But it's a really sad emergency that we have to deal with. So, really self-explanatory. Be prepared. If you know that a cardiac emergency is coming in, or you've got the call, or you've got a known cardiac case that's, gone into crisis, be prepared. And it sounds really silly, but just make sure we're very lucky that we have an amazing ICU team. We also have a great crash trolley. We have oxygen kennels. But I know working in general practice, I worked in general practice for 20 years, we had just like a little toolbox, which was our crash box. And they're great. They can carry all the drugs that you need, all the emergency stuff. So know where it is, get it out, get it ready, and inform everyone that you need to inform in the hospital that this patient's coming in, and be ready and prepared for this patient. So, as I said, obviously prepare all the necessary equipment, get your little toolbox out with all your crash drugs in, get it out, get it ready, and be prepared. Oxygen kennels. We have amazing oxygen facilities. Ours is just a switch that we have to turn on, and then we calibrate our machine, and we're ready to go. Do any of you guys have that facility? Yeah, great. Self-made oxygen kennels? Yeah, okay, but that's fine, and that can take a while. You know, you want to pre-oxygenate the kennel and stuff and have all that ready, and quite often our cardiac patients will need an oxygen kennel ready for them. Emergency drugs, that's your little toolbox that I mentioned, but it seems really silly. If you know the patient and it's a known patient, see if you've got an up-to-date weight, because you can start to calculate the drugs. Obviously don't get them ready because you might not need them, but obviously you can start to work out, because that's quite stressful in a cardiac emergency, having to stand there, draw up drugs quickly and deciding what drugs that you need. So if you know your patient and the sort of weight, the average weight of your patient, you can actually get all this prepared. And also check the dates on your drugs. It seems, I've done it before, I have emergency drugs in cardio, and you know, it's past its expiry, it's been open post 28 days. So before they come in, this is something that I will definitely check. Prepare equipment for IV. Now, some of our cardiac patients will definitely need an IV straight away, but you'll be surprised there's one that I just say hold off, but we'll talk about that. But we have little trays, and it's something we did in general practice as well. Do you guys have little IV trays that you have? And they're great. You just grab them, you get them all ready, and they're there ready and waiting for your patient. And then, obviously, you prepare your kennel. Nice soft mattress if you have them available, and vet bed, and just make sure your oxygen supply is nearby. So these are some of the symptoms that the patients will come in. Obviously dyspnea, tachypnea, that's very common that we get our patients coming in with. Pulmonary edema, sometimes the carers will say there's been exercise intolerance, you know, they're really quite exhausted just walking in. Sometimes we have to get a trolley to bring these patients in, or we'll carry them in, whatever's necessary. We really don't want to put them under undue stress by sort of trying to coax them away from their carers. Arrhythmias, syncopal events, carers may come and say, oh, you know, he's had a couple of collapse events. Ascites, it's not always related to cardiac disease, but it is related to right-sided congestive heart failure, and that's when you get your jugular distension. Has anyone ever seen that jugular distension? It's quite impressive when you see it, and obviously pleural pericardial effusion. So these are all the presenting complaints. Well, there's going to be more, but these are the most common ones that you'll see. Okay, so respiratory distress. Definitely oxygen. They need oxygen. What I always say, it's really hard when you get a patient that comes in and is under respiratory distress, and it could be a naive case, so you've never seen this case before. How do we know it's cardiac? You know, these patients are really stressed, carers are really stressed, and you're not always getting a detailed history from these carers. So it's really hard to kind of decide which way you're going to go. But a one-off dose of furosemide is not going to do any harm. And if it's a patient that's in congestive heart failure, it really needs that diuretic. So you can just give, obviously under the direction of your clinician, just suggest, you know, let's give a one-off dose of furosemide, 2 mg per kg, it's going to be absolutely fine. And then you can place them in oxygen and just stand back. Do not, if they are in a lot of distress, be tempted to place an IV. It's really, I know as nurses, we want to get an IV in straight away. We want to have IV access. I've actually seen patients crash when they've come in congestive heart failure and we've tried to place an IV and they've decompensated so much. So it's really, you know, as nurses, I know we want to get an IV in, but for these patients, oxygen, less stress, and just get an IM furosemide dose into these patients, okay? And obviously make sure they've got a nice kennel ready, a bed ready, and just let them de-stress, let them calm down. We do always say sedation. We tend to use butorphanol, and we might use something between 0.2 to 0.3 mg per kg. And that does help them, because you can imagine if they've been struggling to breathe, you just need to sort of calm them down a little bit, just relax them a little bit. Obviously, everything I'm saying, as nurses, we have to do this under the direction of the clinicians. The only thing that we have found, and I know I've personally found it, we had a little patient in a couple of months ago, a gorgeous little doggy that, and it's, for us, I think as nurses, it seems common practice to say that this patient is really struggling to breathe. But there are some carers that just aren't aware. And this gorgeous little doggy was literally, when I went into the consult room, to triage, was literally head extending, like open mouth gulping. And when we discussed with the carer how long this has been going on for, the carer said, oh, a few days. And you have to hide, like, oh. But some carers just don't see it, you know. They have other reasons. Oh, it's really hot, you know, he probably needed water, he was panting, he was tired. So they're the kind of patients that I would discuss with the clinicians, that maybe we don't give sedation for these patients because they have been fighting just to keep on going for those few days. And then suddenly you suppress them too much, they decompensate. So if it's a chronic case, you know, hopefully you don't get to see those patients, and you feel like, oh God, they've been like this for a few days, just be a little bit cautious with your sedation. Have that discussion with your clinician, because actually it can just suppress them a bit too much when they've been really doing such a good job of fighting. Yeah. As I said, no IV, IM's adequate enough, stress-free environment, and optimal nursing care. So we want to make sure that when we're given this medication, it's doing good. So we will always, in the ICU department, we have amazing ICU nurses, and our kennel chart will have respiratory effort and rate literally constant. So you're constantly monitoring these patients, not standing there gawping at them, because obviously that can be really stressful for these poor patients. So you can stand from afar and just have a look and make sure, and they may need a couple of doses of furosemide, but you want that respiratory rate and effort to be going in the right direction. Okay. So I've just put this little one up here because clinicians, and I work with some amazing clinicians, obviously. As nurses, I think we're the biggest advocate for our patients. No offence, clinicians, I'm so sorry. But they want to get a diagnosis. They want to get an ECG done. They want to get an echo done. They want to know what's going on, because obviously they want to be able to treat the patient. But actually that can be more harmful. But when they do want to, and we do need to see, you know, in congestive heart failure patients, is that left atrium big? Are we treating congestive heart failure? We could do a POCUS. We could just stick on the probe bedside, or if they're able to have some flow by oxygen, this is in our cardio room, just so we can have a quick look at that heart, a quick look at that left atrium. Okay, yeah, the left atrium's huge. Let's pop back to kennel. We don't need a name for this cardiac condition. We just need to know that we're treating it adequately. There's loads of fancy names and terminologies. There's loads of different cardiac conditions. It doesn't matter. Let's just treat what's going on with the patient right now, and a quick POCUS is fine. Okay. Next video is not nice, I'm afraid. So this poor little poppet was a known cardiac case. Doing really, really well at home. We always try to keep in touch with our carers, because we want to check their sleep and respiratory rate and effort at home. Make sure the carers are given tablets. As you know, cats can be quite tricky to give tablets to. You know, you think you've given it and then you find 10 tablets behind the sofa. But this little poppet, the carer wanted to check up, and I looked on the notes afterwards, and we hadn't had a regular sleep and respiratory rate and effort from the carer, and we did nothing to this cat. This cat was really stable at home, doing really well, and this is just sheer... Can we play that again? Would that be okay, Elliot? Absolutely. This is just the journey, the car journey for this little poppet, and you can see how much effort and distress this poor little poppet's in. And we couldn't do anything, you know. We gave some flow by oxygen, did a quick examination, and popped her into kennel, and started her on IM furosemide. And when we spoke to the carer, this carer said, oh, she was doing really well at home, she was eating and drinking, she was having her meds. So just be aware that, you know, you can actually push these little patients over the edge by doing too much. So this is where us nurses come into our own, okay? So when you know you've got a cardiac patient, do you guys all run nurses clinics and stuff? Yeah, okay. So this is where, this is the part that I love about the cardio, because I will also call the carers. If we have a known cardiac patient, quite a lot of my list will be phoning all the cardiac patients, and they will... Does anyone know about the Cardialis app? Has everyone got the Cardialis app? There's a little app that you can get on your phone, and it's really good, and it will get the carers, because it's the most crucial part when the carers want to feel like they're doing something for their beloved pet. You know, yes, we can give medications and stuff, but when you send home a cardiac patient to go home, it's really quite daunting for these carers. They're really scared that something's going to happen again, and how do they monitor their beloved pet at home? And the key is the sleep and respiratory rate. So we always get them at home to check the sleep and respiratory rate. There's a wonderful Cardialis app, it's all free, and we have a little sheet that they send it in to us for the Cardiology email, and then our job then is to check the sleep and respiratory rate, and we want it below 30, okay? And we want the sleeping respiratory rate below 30, and then we just check it, we trend it. So for instance, if the cat or the dog is normally about 16, so 30 seems to be the magic number, but bear in mind, if the normal for this patient is 16, and then suddenly you see a trend that goes upwards, we're still under 30, but we're looking at 24, 28, you know, pick up the phone, have a chat with your carer and say, okay, we seem to be trending upwards. What's happening? Is the patient asleep? Definitely. Are you checking at different times of the day? Or is this a true reading? Because then we can intervene before things become a problem. Okay, so it's a real key thing that we can do as nurses, and we can speak to the carers about checking the sleep and respiratory rate. Okay, effort as well. We get carers to send in videos. So if they call up and they're a little bit concerned, sometimes carers, when they say stuff to us, you think, oh, is that actually really happening? So we'll get them to send in videos, and we can look at the videos and say, okay, there is a lot of effort there. And actually those cases we do need to see because there could be a fusion. So I tend to relate increased respiratory rate. It's not, I suppose, scientific, but I always find that increased respiratory rate tends to indicate pulmonary edema, but increased effort tends to or can indicate pleural effusion. So if you've got a patient that has got increased respiratory rate but a lot of effort, they are unfortunately the cases that you probably do need to get back, because there probably is going to be some effusion and you will need to drain it. So you could give furosemide, you could give a diuretic, but it's probably not going to help that pleural effusion. So it's all about communication, and you can do this from afar. Do they need to come back? Is there an increased respiratory rate? Can we speak to the clinicians, and can they increase the furosemide dose, because that's the life-saving drug? Can we increase that furosemide dose so that it can stay at home longer, or do we actually need to see them? So it's really important, and obviously support the carer. You know, it could be as simple as, I can't give this medication. You know, I'm really struggling to give it. So it could be something like that. And when it's something like a furosemide, and they can stay at home, we just need to support our carers to make sure they're doing everything they can at home. So after initial stabilisation, absolutely, that's where we can get our IV in. That's when we're happy as nurses, and the clinicians are happy because we can now get our IV access in. But remember, these are still quite critical patients, so we need to do things in stages. So what I would tend to do is shave, put some EMLA on, and leave them be. You know, leave them be. You're getting some IM furosemide into them, so that's fine, and then go back to them. Then you can start to do your blood pressure and your blood sampling. Clinicians, this is where they're racing to get these radiographs done and this echo done, absolutely. You can't really confirm that the patient's in congestive heart failure unless you get radiographs done, but you can wait. You can do this in stages. Make sure your patient is stable enough before you go to do those tests. And obviously the most, monitor urine output and keep your bedding nice and clean and dry, because when they're on diuretics, they need access to fresh water at all times, and they are going to drink a lot more and pee a lot more. And there's nothing worse if they're in a kennel and they're having to urinate. And you may find actually some of our patients who are quite stable, and then they're absolutely busting to go to the toilet, their respiratory rate increases. So you carry them outside, they go to the toilet, and then it settles again. So that can have an impact on them as well. And then I just say at the top there, optimised kennel chart, because it's all about the sleep and respiratory rate. It's the key, it really is. It's how we see how stable our patients are. Just to put the cat amongst the pigeons there, but the large breed dogs, the sleep and respiratory rate isn't as sensitive as it is for medium, small and cats. So just bear that in mind. I don't know why, but I tend to find, and it is a known fact that actually the large breed dogs, they could have quite severe cardiac disease, congestive heart failure, and actually they're normal for the sleep and respiratory rate. So that helps us, doesn't it? And the aim is to get these little guys home as soon as possible. They don't want to be in the hospital. It is a really stressful, as much as we try and de-stress the situation for them as much as we can, as long as we've got them under control and we've had really good communication with the carers and they're happy with everything that we're describing to them and they feel supported. So what I tend to do is once they go home, I'll follow them up with a phone call the following day, and then a week later. Because some people just need to chat and just say, look, is this right? Or am I doing okay? So get them home, but just make sure you support the carers in this journey as well. Arrhythmias. This is why I get quite excited about arrhythmias, I'm sorry. And it was listening to Lucy, I do like the arrhythmias. Okay, so arrhythmias. So it really all depends what arrhythmia the patient is having, depends on their clinical presentation. Okay, so Was anyone here when I did a talk on auscultation murmurs? Did anyone? No one? Oh, there was somebody. Okay, so nurses, listen, auscultate your patient. It's vital. You can actually have a really good differential diagnosis just by listening to your patient. A stethoscope, that's all it is, and you listen. Like we talked about atrial fibrillation, Lucy talked about atrial fibrillation. Anyone know what that sounds like? It's classic. Trainers in a tumble dryer. It's really chaotic. If you ever hear atrial fibrillation on a stethoscope with your patient, you'll look amazing because you can say to your clinician, "Oh, that sounds like atrial fibrillation," because it's really chaotic. Just pick up your stethoscope for every patient. I'm going off on a tangent now about auscultation, but just listen to your patients when they come in because it's really key, and especially if you've got an arrhythmic patient, if you listen, you'll have a good idea what's going on, and also feel for the pulses at the same time. Are there pulse deficits as well? So the things that we look for when we have an arrhythmic patient is the patient collapsed or weak, pulse quality, and auscultation. It's vital. Okay, so these patients, this is where we do. Absolutely, you get an IV in straight away. Just get an IV in, regardless of what the arrhythmia, they're fine, just get an IV in. We obviously need to identify the arrhythmia, so attach an ECG. Avoid stress, that's that word again, as much as we possibly can. And some of these patients can come in and they can be really, really arrhythmic and actually look quite bright. So don't be fooled by their clinical presentation. That's why you listen to find out what's going on and you feel for their pulses. And there we go, good communication. So not just good communication with the carers, but good communication with your team. Because, look at this one.
Well, I guess the question is,
yeah, that's quite interesting. That, obviously, someone's filming, but the patient is being treated at the same time. I get really excited about these rhythms because they're quite, they're quite juicy, if you like. That's naughty. That's a naughty rhythm. Has anyone had any of these in practice? Yeah, they're quite. You can feel your own heart probably when you see these. Hey, yeah, they're quite interesting. So these patients normally come in and they are quite collapsed and weak. Saying that, we had a Labrador that came in and we listened and we put an ECG on and we had a very similar rhythm and the Labrador just wanted food. I mean, it was unbelievable. So they can be quite, animals are just amazing, aren't they? They can. If this was a human, whew, but animals can be walking around, waiting for their next dinners. This is another example. It's a paper trace. So this one we get very excited about. This one, yeah, okay, but we've also got some sinus. We've talked about sinus, I can't. So if you look at lead 2 at the top, you've got P, Q, R, S, S, T, and then you've got some wide and bizarre bits. So yes, that is VTAC, but it looks like it's a non-sustained VTAC. You would still treat, obviously, but it was just to give you 2 variations of what it can be. And obviously pulses, check your pulses, check your blood pressures. Have you got a good cardiac output? Ventricular tachycardia, obviously the one that we've just seen at 230 beats per minute, it needs to be treated straight away, and obviously you have to have your clinician there straight away. You place an IV and you attach an ECG. These patients are at risk of sudden death. So you do need, if you know a patient's coming in and it's in a ventricular rhythm, because quite often, you can maybe tell from the history or even when they first come in, it's always good to have your team prepared to commence CPR if needed. So get your roles decided, have all that, and it almost wards off evil spirits, I think. If you're trying to get all your crash stuff out and you've got all your team, like even if you have a patient that you think might go into VP, so in a cardiac intervention, they'll have drugs ready just in case, because it wards off those evil spirits, and hopefully you'll never need it. That's kind of what I always think. So ventricular tachycardia is normally a very fast rhythm. It will cause a reduced cardiac output, and you need to treat straight away. The treatment that we would do is lidocaine. Lidocaine. You need your lidocaine. And as Lucy's already mentioned, it's normally 2 mg per kg IV. Cats, it's toxic to cats, as already mentioned. So we tend to use a quarter of the dose to see if it helps, but it is toxic to cats, so just be very, very careful with your dosing on cats. Our aim is to convert to a sinus rhythm, okay? But quite often we may just reduce that rate and we may get the VTAC, if you like, or ventricular rhythm interspersed with sinus, and then we're happy. When we see that, we're happier. We do also need to get oral antiarrhythmics on board, because we want to get these patients home, and you can't send them home on lidocaine to control this rhythm. So we need to get an oral antiarrhythmic on board at the same time, and it's normally something like sotalol that the cardiologist will recommend. Really important from a nurse's point of view, with antiarrhythmics, they can be pro-arrhythmic too. So when you are discussing with the carers about the tablets, they have to be given Q12. They have to be given on time, no erratic dosing at all. And also, you should never break a tablet up. So like it might be on, I don't know, if the vet or the cardiologist wants to give half a tablet, you can say, no, don't split up doses. They have to be whole tablets. Because as you know, when you go to break up a tablet into quarters or halves, is that really a half? Is that really a half? And because they're pro-arrhythmic, you have to be really, really careful. So don't split these tablets up at all. The other thing actually I was going to say as well is with lidocaine, if you're ever in that situation with a VTAC patient, it's really, really tempting to give the lidocaine really quickly, and I've done it, and it can cause seizures. So I have given it very quickly. I was really kind of, oh my God, I need to help this patient, and I was asked to give this lidocaine really quickly, and the patient became very neurological. It was very transient, thankfully. So we normally give lidocaine 2 mg per kg, and we normally give 3 boluses. And we give each bolus over 2 minutes. So if you're ever given lidocaine, even though you really want to help this rhythm, please give it slowly over 2 minutes, okay? And then they normally go on to a CRI of lidocaine. And also, because you're looking at this awful rhythm and you're just thinking, oh my God, I need to get this dog into a sinus rhythm, remember lidocaine can also make the patient feel a bit nauseous as well. So speak to your clinician and see if you can get some meropitant on board there as well. It's not the essential drug, but just for if they're in and you're trying to get this rhythm under control, just remember that as well. And then we need to obviously investigate the underlying cause. When it's that fast, when it's like 230 and it's sustained VTAC, yes, chances are it's going to be cardiac. So we do need to investigate what's going on, but sometimes it might not be cardiac. So remember that, as Lucy's already mentioned, it could be something systemic going on. And unless you treat what's the underlying cause, you're not going to be able to treat that rhythm. So just have that, bear that in mind. Regular monitoring. So if they are a true cardiac case, we will obviously start them on antiarrhythmics to go home with. And then these are the patients that we do need to get back. Because as I said, antiarrhythmics are pro-arrhythmic, so we need to make sure the medication that we are given is actually doing the job that we need it to do. There are different antiarrhythmics, we may add in different ones, and we want to make sure we might not convert them completely to sinus, but we want to reduce the amount of ventricular rhythm that the patient is having and make sure it looks more benign than more of a malignant kind of rhythm. And there we go, the good carer communication again is essential. Antiarrhythmics are pro-arrhythmic, make sure they're given on time and you don't split up the doses. And this was just, I don't know if anyone has ever used a halter in practice. Has anyone ever used a halter in practice? Yeah. So these are, I think whatever cardiologist department you go to, they're all different devices, but they're principally the same. So these little guys that are on antiarrhythmics, we will monitor them. Once they've been on antiarrhythmics for 2 weeks, we get them back and we put a Holter monitor on, stays on for 24 hours, and we just make sure that the medication is doing what it's meant to do, and we can change the doses. And they also get to wear these lovely little jumpers, which I think are really cute. So I'm not sure the dogs like them, and we do it on cats too. So cats are, we can do Holters on cats too. So next one, pericardial effusion. So quite often, when I mentioned about pericardial effusion, people did say they do pericardocentesis in the practice. Yeah, it can be quite scary because you're going in with a catheter, you're tickling that heart, and hearts don't like to be tickled, obviously. So there we go. So there's, can we play that again, Elliot? Would that be okay? Sorry, thank you. There's an example of a pericardial effusion. There's quite a lot of effusion there. It's also, at the far corner, you can see a tamponade of the right atrium. So these you have to act straight away. Yeah, and these can happen really acutely. So carers, 1 minute their dog's absolutely fine, and next minute, they're off their food, they're vomiting, they're retching, they're lethargic, and they come in and we can see that there's pericardial effusion, and we have to do something about that. Sometimes you can get trace pericardial effusions and we don't treat as much, but this, when it's tamponading, we definitely need to do something about this. So yeah, it's very normally observed in large breed dogs. I think I've only ever seen it once in a small breed, and that's a Jack Russell, which was really obscure. It's not something that we normally see. Obviously, it's accumulation of fluid, but it can be blood, it can be serum, it can be chyle, it can be pus, and it's in with that pericardial sac. So you can imagine the heart is trying to beat, and it's getting squashed with all that fluid that's in that sac. That sac is meant to protect the heart. And as I said, they can present lethargy, respiratory difficulty, falling, reduced appetite, vomiting, and abdominal distension. And yeah, it needs treatment straight away. So the two main causes of pericardial effusion is either going to be a mass or idiopathic. And this, going back to the carers, this can be a real shock to them. But here, and the most common cardiac masses is going to be your hemangiosarcomas and your chemodectomas. We can generally have a good idea of what they are in the position they are of the heart. So this is sitting in the right auricular appendage on the right side. So the top differential, obviously we can't confirm, is going to be hemangiosarcoma, which carries a really poor, grave prognosis. We do send them to our wonderful oncology team, and they tend to do debulking and can offer chemotherapy. But the prognosis for these guys is a couple of months, maybe a bit longer. I know at the minute the oncology team have got a case he's doing okay at 5 months. Yeah. So to actually go out and speak to the carers about this is, they completely, wasn't expecting this. Then we have to go out and tell them actually this is really quite terminal. So this is where the nurses come into their own play, support the carers. And understandably it's a really difficult conversation to have. So obviously we have to go out and speak to the carers. If it's idiopathic and we can't find any reason as to why there's a pericardial effusion, or it's a chemodectoma, that they can be a benign kind of incidental finding that's found around the base of the heart, we can offer a pericardial centesis. Do you generally sedate your pericardial centesis, guys? Who's ever does them? Yeah. Do you do a full general anaesthetic or you just do sedation? Depending on what the patient's like. Yeah, you've got to be careful because some of these patients are compromised, so you don't really want to be giving them a whole heap of drugs. So we tend to, obviously we have an amazing anaesthesia team that we go and ask advice from, but we will tend to give them sedation, and we use local as well. When we normally do a Seldinger approach, and we'll do a sedation and a bit of local on the site as well. Risks, you're going to tickle that heart when you go in with a catheter, so you're going to cause probably some VPCs, ventricular rhythm. So when we do pericardial centesis, it's kind of our job as nurses to have a look at that rhythm and let the vet know, actually we're getting some VPCs here. We're kind of tickling the heart, and the heart's not liking this. It's normally an instant relief. As soon as we drain that fluid, it's normally an instant relief for these patients, which is lovely to see. And also, we tend to get a little bit of the fluid and we put it into a tube and just make sure it's not clotting, because obviously we don't want it to be clotting. We want it to be a nice free fluid. If it's clotting, it could mean that we've perforated the heart. So it's a key aspect of our nurses that we do have a little tube and we make sure it's not clotting, and we just rotate it. And I've done it loads of times and the vet's like, Emma, is it clotting? I'm like, no, all good, let's continue. So that's a real key aspect, as well as look at the ECG. It's really important to look at that at the same time. And then obviously we've got the prognosis. It can be, if it's idiopathic, then who knows? We've had patients that have come in, had a pericardial effusion and never had it again, which is great. If you see a cardiac mass, then obviously that's a difficult conversation with the carers. And then sometimes, and it's okay that they don't want to go ahead because prognosis is so poor, but you can't leave these patients with this fluid. You have to have a discussion, and it could take all day. They can sit with their pair and they can have that discussion, but it wouldn't be ethical to let these patients go home with that amount of pericardial effusion. Okay, so this comes on to the feline arterial thromboembolism. Has anyone dealt with these cases in clinic before? Yeah, it's really, really sad. God, my talk sounds really sad today. I'm so sorry. These are really sad cases. And do you find that most of them don't then get treated? Do you feel like carers are just, okay. Yeah, so we always have that difficult conversation. We do get a lot transferred to us, absolutely. And there's some prognostic indicators that you can take away, hopefully today, to give you an idea of how well this patient is going to do. So, as you know, it's a clot that spontaneously forms in the heart, and then bits of it can break off and lodge in the aorta, and then descend in aorta. So it can affect 1, 2, 3. I've seen, like I said, the patient that we recently had affect 3 limbs. It normally affects cats that have pre-existing cardiac disease, and strangely enough, male cats are overrepresented. So it's just an interesting fact there. It's really quite sad because, as I said, quite often cats, as you all know, they hide their disease. They're so good. Like, cats can have significant heart failure and have no heart murmur whatsoever. So you could listen to a cat and auscultate and you would have no knowledge of whether they've got cardiac disease or not. So quite often when these patients come in, the carers have got no idea that their beloved pet has got significant cardiac disease. So that's the real tragic side of this, is that they come in, they have a real awful episode. What is the first thing, I don't mind if anyone, would you do with these cases when they come into clinic? Analgesia, yeah. So to be so graphic, but they are very vocal, they do cry out in pain, and quite often carers believe that they've been involved in a road traffic accident, and because they're dragging their legs or leg, and they're in so much pain. So I don't know if you can see this. Can you see, this is the left auricular appendage, and, it's gone again. Can you see the smoke whirling around? So we call it smoke, or it's called spontaneous echo contrast, and it's where they've got significant cardiac disease underneath, and the chamber's just got so large. There's lots of different factors, but this is smoke, blood just swirling around in that chamber, and it's a precursor for a blood clot. So if you see that in an echo, it's not good news, sadly. So yeah, on presentation, it's severe pain. So you can't handle these patients when they come in. You have to give them pain relief, and I mean big guns pain relief. You want your fentanyl, you want your methadone. You want strong pain relief on board of these guys, and it needs to be for at least 24, 48 hours. Okay, they come in. This is a real. Can you see this patient had one limb affected, and you can see the different colours. So this is nice bright pink, and this is quite pale. So this is where there was no perfusion getting through to that pore. So you can see, it's not a nice picture to see, but obviously you can see how clear that is there. So they come in and they can have paralysis or paresis of 1, 2 or 3 limbs. I mean, as I said, I've only seen one cat, and it was recently with 3 limbs. They've got no palpable pulses in the affected limb, and you can see the pads. Obviously it's different in a pads that are dark, but you can see there that how bluish they look. Profound weakness, and they have low body temperature generally. Not always, but they have low body temperature. But the most important thing is pain relief, pain relief, pain relief. Get pain relief into these guys. So then for these cats, they're quite intense nursing considerations. Some carers would, once they find out, and they have got, quite often they've got significant cardiac disease underlying, and they decide not to take it any further. And that in itself is really traumatic for them, but it's completely understandable. But we need to then step up as nurses, make sure that if they are going to go ahead with treatment, for instance, our lovely little girlie, that was affected, they just couldn't make a decision straight away because it was all so new to them, they wasn't expecting it. So for us, absolutely, we have to manage both patient and carer. So we make sure that she's not in any pain and she's really comfortable, and then have these difficult discussions with our carers. So we want to give them pain relief, absolutely. We want to avoid stress when they come into the hospital. Nutritional support, they're not going to want to eat. So as Laura gave an amazing talk on nutrition, we do need to take that into consideration. We want to keep them nice and warm, but no direct heat, because remember, they're not going to be able to move away from the direct heat. We need to have a litter tray in there, but not a litter tray, like a normal litter tray, because they're not going to be able to get into that litter tray. So it's all these kind of things that you need to think of. They're not going to be able to get into that litter tray. So just maybe a little Inco pad with some litter on it. Constantly check and make sure that their bed is clean and dry, because they can't actually generally move away from the soiled bedding. So all these types of nursing considerations, which is what we do every day, but just take that into a special account when it's these patients. Monitor your vital signs. These cats are at risk of reperfusion injury. So when the a clot dislodges, then all the toxins that are built up behind then flood the limb, and then so we need to keep a monitoring check of their electrolytes to make sure the potassium's not going up. Obviously pain, just make sure we're keeping their pain under control. What else are these little guys? I think that's, it's just, they're really sad cases. They're really intensive nursing cases. So you have got some poor prognostic indicators that you can actually have in mind when you are speaking to your carers. So if they've got a low rectal temperature, if they've got underlying congestive heart failure, or 2 or more limbs affected, they're the poor prognostic indicators. So it's nice to have that in mind, that when you're speaking to these carers, it's the first they've ever heard of it, but you can sort of guide them to make the decision that's right for them. Long-term survival is not great, and then obviously the reoccurrence risk is up to 50% in cats. Saying that, I used to work for a clinician where she had a wonderful cat called Smokey, believe it or not ideal, and that sounds awful, but it was called Smokey, he was, yeah, did really well. Did amazingly well and lived for another 3 years. So these are statistics. You know, you need to bear them in mind. They're numbers, they're statistics, and you're always going to get, especially cats, you know, they prove us wrong all the time. Just, you know, bear it in mind, numbers, but, you know, we can try and offer them as long as it's a good quality of life. That's the most important thing. Okay, so the take-home message. Stress, reduce stress for all our cardiac patients, be it congestive heart failure, be it arrhythmias, be it poor little feline cats, whatever. So reduce the stress for them. Consider sedation, obviously, for our patients. Bear in mind the patients that are chronic, that we don't want to suppress them too much. Can we monitor from afar? Can we get that really good communication between our carers and us to see what their sleep and respiratory rate has done? Get that app going, get them to send in the app to us so that we can have a look. Pain relief, absolutely, for our ATE cats. That's got to be the first protocol. Don't worry what the underlying condition is, get that pain relief on board. Good communication. And there we go. So advocate for our patient and be supportive for our carers. Be there to sort of listen to them, talk them through the process. And just be there to sort of listen to their concerns.